The first couple of slides that we're going to go through are our required disclosures for CME and continuing education. At the end of the session today, you will receive an email with instructions for obtaining your CME certificate for the entire series. And so without further ado, I'm going to go ahead and turn this over to Dr. Kelly, who we have back to facilitate today's session. If you need information on her background, you can reference the first two recordings for her bio.
Okay. Hello, everybody. Today's going to be a little bit of a review and pulling together what we've learned and how to apply it in a hurry if you need to. Just to remind everyone, we talked about the rationale and role of leadership. We talked about data collection and analysis, the policies that you need to have, the infection control aspect of stewardship through prevention of infection, practices and processes that you need to have, working with your data, and then working with the microbiology lab. So today we're going to talk about how you can present an improvement process from your rationale to data collection and then analysis, and how you can maintain continuity of your activities through continuous assessment and reevaluation and keeping good records. And then also how you can use individual cases and storytelling to motivate staff and prescribers. So what have you heard? Surveyors were coming to your facility next week. Are you ready? So I think there is a rapid response that can happen that would be a compressed version of what we've been through since November. Getting leadership support, assembling a team, announcing the program, and reviewing the available data to you to take action and begin your program. Now, what we've done for this session is pull together a sheet that describes all the tools that are on the website. Most of the tools, not all of them are posted yet, right? Including this sheet, but the sheet was circulated to you in advance. Because as I went through this, I realized we put together a tremendous amount of material and tools. The way it's on the website is a little overwhelming, just looks like a long list. So we actually put together a more organized, grouped 4-page document that describes our tools. So let's go back to the slides for a sec. This is the document that everybody should have. Might help to print it out. There we go, okay. And this document will go on the website. So let's talk about how you would get going quickly with a program. We have the hallway poster available to you. And then we have the suite of CDC documents that lay out the elements of stewardship, basically the 8 core elements. The CDC also has 3 appendices to that core document, and the appendices lay out the checklist. Actually, it has 4 appendices. It has Appendix A, which is the core elements for nursing home, and that's a more detailed explanation. It has a Appendix B, which talks about measures that you can be looking at to count how you're doing with your stewardship. And it has C, again, this is more measures and data related. And then there's a basic checklist that will help you do a quick survey of how you are doing with your program so far. In terms of other CDC documents, there is the environmental cleaning checklist that people have used for training their cleaners, together with a fluorescent marker, for instance, that you can use with an ultraviolet light. And then there's some leadership flyers, which are a quick way to educate your leadership about antimicrobial stewardship. And then later on, the CDC also provides some patient education. So those are the core CDC documents. But I think the poster has been really well received, and we actually printed it, right, for a number of people. And if you want the poster and you don't have it yet, please contact Andy and get a poster. This is, when people are hanging around in your hallway, families, patients, having something on the wall for them to read is really nice.
And the poster was also developed as an 8.5 by 11 flyer for those areas where you can't put up a big poster, or also to use as an insert for maybe your patient admission or your resident admission packet.
Right, so educating families and patients on the, just what your attitude about antibiotics is from the outset, and presenting stewardship in a positive light. So how can you get started quickly? We actually put together a lot of good materials for you. There is a committee roster that outlines who should be on your committee. We have a committee agenda, which is a sample document that I used back at the VA that has been reformatted by Health Insight. And you can also use this to type as you hold your meeting and generate your minutes. Keeping a good record of what you do is really important for when surveyors come, and we'll talk about that a bit more. And then communications to prescribers, announcing your program to prescribers so that they know there is a reason for this. It is a CMS requirement, and this is how you're going to approach it, and it's for patient welfare. So here are some other tools that are on the website. The data deep dive, starting your committee with a sample policy that is the policy document that supports your committee, that says your committee is going to be gathering data, looking at it, analyzing it, making recommendations, and then implementing them, enforcing them, and then looking again at data. So that's the policy in a nutshell. And then in that second webinar, we also had some tools for rapid data collection. One of them was the point prevalence tool. If you needed to look today at what antibiotic use is going on, this tool is there to support and help you collect all the elements when you review the patient's charts, so that you're getting a good picture of your antimicrobial use for that day or that week. Then you want to have policies. So in addition to the policy for the antimicrobial stewardship program, you want to be very clear to your providers that there are basic requirements for prescribing as regards the dose, the frequency, and the duration of antibiotics, and the indication for why the patient is getting them, and whether or not that's for prophylaxis or treatment of an infection. And then we also gave you the behind the scenes document for CMS, which is what they're looking for, their survey document, their checklist, so that you can have an answer for every question that they're going to ask you as they go down their checklist to make sure you have a program in place. So a few other tool highlights. There's actually a lot more than this on the website, but I think what we got the most positive reaction about were a few things. The Foley observation tool, i.e., there is a way, if you have patients that have to have Foleys, there's a way to take good care of them and monitor that and measure it, and teach your staff that the bag has to be below the level of the bladder, and we do hand hygiene when we touch the Foley, we wear gloves appropriately, and how we take cultures and why we take cultures and so forth. So that was very well received, and it pops out little graphs for you and things like that. So some data that you're collecting for quality of care. And then practices and policies. Educating your families about UTIs, what they are, what they aren't. Just cloudy looking urine or bad smelling urine is not necessarily a UTI, important education. And then medical care referral form so that we have standard communication about patients' conditions that will help people adhere to the next part. Another tool that we provided was a card that described the minimum criteria for initiation of antibiotics in long-term care, which is based on some guidelines from the American Geriatric Society. So if you only have one of these criteria, you don't meet the requirements that are recommended for initiating antibiotics, but observe the patient and be aware of what other criteria might be. So webinar 6, we talked about getting your data, analyzing your data, and this is the data collection sheet that is used in acute care hospitals adapted for long-term care. And it has some drop-down menus to speed up your data entry and come up with some summary data for the month. But in order to have a program, you have to be tracking and analyzing some data on antibiotic use. It doesn't have to be every drug. You might say, we looked at our purchasing data or pharmacy data for the year, and we decided we had a problem with X. So we went on and prospectively reviewed all patients who were given drug X to see if they met criteria. As long as you can rationalize what you're doing and show that you based it in data collection and analysis and a risk analysis of your program, you will be okay. So that was one of the biggest, I think, issues when I was in acute care, infection control, for instance. It's all about risk analysis and knowing your patient population. And people would attempt to do things like track every little infection and so forth. But if you can justify based on your population what you're tracking and why, and that you've done a risk analysis and you know the kind of issues your patients have, that is what you need to be doing. Is very powerful because it shows that you put some thought into it and aren't just collecting data willy-nilly. So then the webinar 7, another thing that you want to have somewhere in your minutes is the antibiogram, and have some minutes in your committee of a discussion about its relevance to your facility and making it available to your prescribers. They will be looking for some kind of antibiogram. It doesn't have to be facility specific, although many labs do provide that. It can be your local hospital's antibiogram if that's where a lot of your patients go to and come back from, and you can't get any other antibiogram. So then there's some other audits that you can do when you're working with the microbiology lab. How good are you on C. diff testing? Are all of the stools meeting the criteria for being liquid stools? Are you sure that you're not taking urine cultures from patients whose catheters have been in for a long time? Because then they will be colonized and it won't be a great culture. So these are all things that can be audited, generate some data, teaching, feedback from that. So here's our first polling question. Our facility has a structure for antimicrobial stewardship that provides for continuity regardless of staff or prescriber turnover. How do people feel about that? Do you have stuff down on paper? Is there somebody, is your group large enough that if somebody leaves or even goes on extended medical leave or vacation, that there's somebody else there who can carry on, who knows what's happening with the program? Disagree, yeah. So continuity, which is what this webinar is about, is really important. As we know in quality control, infection control, there are so many good intentions. People get started on stuff, and then it's all individual dependent. And the individual leaves, and then we're back to square one. What can we do about that? It's because, you know, turnover is a chronic issue in healthcare. So the binder is key. I can't tell you how many times surveyors would turn up, Joint Commission, CMS, whatever. They wanted your binder. They did not want to sit in front of a computer and have you show them Word documents. They wanted a binder in their hand, and they would sit with it for hours in the room. So the fatter the binder, the better. Kept them off your other areas. So if you can make a binder that is printed out with your policies, your agendas, your minutes, printouts of your data, records of all the surveys that you took, audits and analyses on paper, and then samples of your educational materials that you're using, that is a great tool. And it's a great sell of your program when you have that all together in place. And maybe the person who knows what's going on is not there on the day of the survey, but everybody needs to know you have the binder. And working too much on computer system, I've worked with staff who did things like save documents to their desktop and not to a shared drive. And then people would show up or they would leave and we'd be looking for their data. So it's really helpful to have things printed out and in the binder.
Dr.
Yeah,
Kelly?
question.
In terms of the binder, it's not static, right? It's
Right,
dynamic.
yeah.
And so how often should it be updated?
Well, I think you have to be ready to present your binder. And so everything in your binder should be dated, like the policies. When you put the policy into the place should be dated, your agenda should be dated. The more you have in there, the better. And so usually the binder will go back to your last survey, which may be 3 years. I'm not sure how often long-term care facilities get surveyed, but we used to be surveyed about every 3 years, and we would have at least 3 years in there. And then the other thing that people like to see in infection control that was also powerful was, I would call it megatrends, and I would look at summaries of year-on-year data. But it takes a long time to build that. But I think if you're just starting out with a couple months of work, you'd be surprised. You have already generated quite a lot of material if you have policies, agendas, and minutes, and some data analysis is quite a lot to go through. And, people forget stuff when they're talking to surveyors. People are flustered. And so focusing on a printed document is really helpful. So uses of the binder, pass on the knowledge to new employees and preserve institutional memory so it's not just in somebody's brain. Review times in the past when you went through the same issues. I can't tell you how many times it was reinventing the wheel, You also get perspective on what's going on now, because maybe in the past your problems were much worse, believe me. And then you want to have some discussion of your rationale. So for instance, if I think about MRSA in the VA, when we got MRSA somewhat controlled in the VA, and this is happening across the country, there's a strong pushback. Why are we doing contact precautions? Why are we doing active surveillance testing? And people don't remember how bad it was before we did those things. So your data is very powerful to say, if we don't have this program, we're going to be going back to using X drug on everybody, and then we will go back to having the kind of C. difficile that we had 10 years ago. And it's important to be able to look back at that. And then the other thing is the continuity. Sometimes things have to be dropped. A drug is not approved or a vaccine isn't available, but you have to keep it on your agenda, and eventually you will get to it, because often we're dealing with putting out fires and so forth in stewardship and in infection control. So here's a polling question. Our facility has a process to educate staff, providers, residents, and families about our antimicrobial stewardship program. What's our process? Do we have flyers? The poster is up. Have we sent out letters to our prescribers? Have we described that process? For instance, when we have a new person on the prescribing staff, do they get informed about that? So a little bit wishy-washy here. A process. How are we going to educate people on our program? So one way to do it, which is nice, and also is great for when surveyors come, is to showcase a project with a poster. So you will get there, and as you crew your work, you will be able to present some evidence of change, or at least implementation, even if your outcomes don't change that much. So you're going to have a team, which is your committee, a problem, which is what you observed in the course of analyzing your baseline data. You're going to have some kind of response that you did, whether it was education, creating a new policy or changing a policy, or implementing a new process. And then you'll have a repeat data measurement, and then you'll be analyzing again. Did it work, what we did? Do we need to do something else? What worked, what didn't, what was the response to what we did? So when you're putting together a poster, if you've got a color printer, you do not need to go and get a whole fancy poster printed out. You just need, a display board. It's nice to use color for your background mounting. Get one of those things from Office Max. It's a color display board. I've been through some school things with my son, as you can imagine. Use some color in graphs and pie charts. Show how you collected your data, and credit the staff who helped you as well as your immediate team, so that when people are walking past the poster, they see that, oh, it's the staff of West Wing or whoever were critical in implementing this change. And that's a nice reinforcement for people. So it can be very simple. You can put 3 printouts on a display board. You can make 6 printouts depending how much material you have to put up there. What I would advise is don't start with the title, do it last. Because the title will come to you after you've worked through what you went through, and then you'll have a catchy title that you can put up top. You'll have your team described there, maybe even a photo stuck on of the team, why you did the project, what was the background, what was the purpose of it, the tools that you used to collect the data, the sheet. Don't, of course, put actual patient information up there, but you can describe or show the blank sheet that you used. And then the results can be a baseline only, or before and after, side by side. What you did, it could be we implemented a checklist, we did a policy, put those policies up there, and then an analysis of what happened, any findings, observations, and then acknowledge and thank everybody involved, including the staff, families, and this is a nice way to promote what you're doing. This tremendous amount of work, you'd be surprised when you think about it, how much goes into even a simple project. So uses of the poster, great talking point when the surveyor comes. Good to talk about with staff, residents, and families. I've been to so many small facilities in New Mexico that do a nice job with, say, employee of the month or something, or patient safety hero of the month. They have a huge poster up in the front hallway. They describe what that person did in preventing a medication error or something like that. And recognition is extremely important for your staff. And then the other thing is to empower other staff to come forward with issues needing quality improvement solutions, and make it clear that frontline observations and thoughts are welcomed in promoting patient safety. So polling number 3, our facility celebrates and recognizes successes with staff, prescribers. I would add families there. Do you have a process for celebrating things that go right? Recognition of individuals? Very important, as we'll talk towards the end of this talk, to engage employees in a positive way. It doesn't, people respond to things like Employee of the Month or Employee of the Year. At the VA, you used to get a parking spot that was close to the hospital. But, and that doesn't cost anything, right? You just give somebody a parking placard once a month and recognition, and they like it. So employee recognition is tremendously important in all industries. In healthcare, it's particularly important, I think, because we know that we have a huge range of reimbursement in healthcare. The work is extremely difficult that we do, very demanding. So here's one look at nursing assistants. I'm trying to remember which state this was. I think somewhere in the Midwest. The results indicated that 60% of the nursing assistants were satisfied with their jobs, but 30% planned to quit. So what really was keeping people in their jobs was the relationship with the resident, and having that be recognized and caring about people was their major reason for staying in the jobs. They were most dissatisfied with pay, benefits, and recognition and appreciation. So it may not be so easy to come up with more money for pay or benefits, but recognition and appreciation are not actually that expensive to do. And they make a huge difference in the atmosphere of the workplace, as I think we've all experienced. So here's a psychological or business publication approach to job satisfaction. What are the 5 areas of job satisfaction for your employees? The work itself, it's interesting, there's responsibility, interest, growth. A lot of our employees are in fact going to school on the side. They are looking to move up within healthcare. The quality of supervision, both technical help and social support, having good managers. Then the relationships with coworkers, again, this can be fostered by good managers. And then promotion opportunities, chances for advancement, and then pay, adequacy of pay and perceived equity vis-a-vis others. This has become a huge issue, especially now that there are all these websites where people can see what other people are making in similar jobs. So healthcare workers are very prone to burnout. And burnout happens most often to those people who are the most dedicated and committed to their positions, have poor work boundaries, and who have an over-excessive need to give. I'm sure this is ringing bells with many people. I think nurses are particularly guilty of some of these characteristics and put themselves at risk of burnout. So healthcare workers are at high risk because we are so emotionally involved in our work. People take it personally when bad things happen to patients, whether or not that's actually warranted. So the work is hard, mentally hard, physically hard, and there is emotional work to it as well. We are not sitting behind computers all day long looking at spreadsheets. So people, families, very demanding. So probably burnout is due to a combination of the stressful work environment and the individual's difficulty balancing self-care with commitment to their job. So what does this all have to do with stewardship? I'm kidding there. So one of the things, burnout is also a huge topic right now in medicine and among physicians. And they have pretty much found out that what is burning out so many physicians is that they are now stuck behind the computer. And what really kept them going was having relationships with patients, but now they're behind the computer checking boxes. And anybody who's gone to a physician in the last few years knows that it takes a lot of work to keep the doctor engaged and not looking at the computer, which they have to do to make the record. But of course, the other thing is there's very little space in these records for any indication of who the patient really is. And that's also very difficult for physicians. So you can turn your anti-burnout projects as a manager into quality improvement. So many people are driven crazy by things that happen all the time and keep going wrong, and they're never addressed. So bringing those issues to the fore makes a great quality improvement project. The electronic health record, people need to pay attention to whether or not they're using that in such a way that the electronic barrier gets in the way of your healthcare workers' contact with the patients and residents. So the other thing is prevention needs to be recognized, and absence of problems needs to be celebrated, not just responding to problems. This is one of the biggest challenges in infection control, is actually celebrating what doesn't happen. This is maybe why we have measles right now. We didn't celebrate for many years that we had very little measles, and look what happened. So there are ways to celebrate infection prevention. For rare events, focus on the time elapsed since the last event. So this used to be big in factories, right? 6 weeks since the last accident on the assembly line. So it is now 6 weeks since the last casualty on Ward Z. And you know, you can recognize that you can have a story about Mrs. So-and-so had a casualty, and we put into place our new policy for monitoring Foley care, and we haven't had a casualty since then. So people will remember those events. So that's what I mean about using anecdotes and patient stories. That patient's outcome maybe is what precipitated our work. And so this is why we do it. Keep them connected to patient events. And this is why we do it. And look how well we've done. We haven't had another one. So celebrate those things. You can do that by counting the time since a low frequency event. And then you also have high frequency events, looking at hand hygiene. So this would be a sample graph. It's great. We did well at the VA by having competitions between units and celebrating with pizza parties or whatever. For the residents, even chocolates did well. But important to say, out of 328 opportunities for hand hygiene, we had adherence 82% of the time. That's actually really good. Trending, make a little competition, and you'll be surprised how involved units can get. And then you have nursing staff, assistants grabbing people and saying, wash your hands or we're not going to get the pizza this time. You know, really, it works. And they start to police their unit and police each other because they're getting a reward. It's not always negative. So use your frontline staff to find out why one ward did better than the others. We don't have enough hand gel on the walls. It's not getting refilled by housekeeping. And then there are positive deviants. This is an actual term in sociology, which means people who find ways to succeed even when they have no extra resources. And it actually came out of anthropology. The person who invented this observed that in very poor Vietnamese villages, there were always children who were better nourished than others. And they looked and saw that the children who were better nourished than others and keeping on their growth curve were getting fed little freshwater shrimp out of the rice paddies by their mothers, adding that extra protein source for the kids. And so those mothers were positive deviants. They figured out how to feed their kids better, even when they had no apparent extra resources. So frontline staff will have insights into what's going on and why things don't work. So take periodic looks at your program. We provided the tools for this, gap analyses for the structure of your program. Do you have the right committee? Do you have minutes? Activities and sustainability gap analysis documents are also there in the tools. Keep going back to the checklist to make sure that you're filling in the core elements. So for our participants, really important to recognize the creation of your antimicrobial stewardship program and team. So, and let your facility know what you did. If you have a newsletter in your facility, let people know that you participated in webinars, looked at data, and implemented policies and processes and created a binder. So don't let your work go unrecognized. It's really important. So let me just bring up the document for 1 second here, just so we can wrap up with an overview of some of these tools. So this is the CDC suite of tools. We're discussing the basic handbook, the 3 appendices, some other things the CDC has for leaders for environmental cleaning. And then we provide the CMS surveyor document. Let's go down. We have the committee tools, which is the policy, the sample policy, the sample agenda, the roles and responsibilities for the team. And then at the top there's that antibiotic prescribing addendum, which is the policy that everybody's going to provide all the information when they prescribe. And that's a great thing to survey and look at and get feedback if it's not happening. Then going down, we had some communications tools for education. These are pitched to patients and families from the AHRQ. We have the pocket cards for infection control. We keep going down. We have the medical care referral form, which is a 1-page form with the information that should be collected when a resident is being referred to a medical care provider or going to the emergency department. What's been going on with them? What deterioration have they had in their functioning? What are their vital signs? What are their medications? What's their history? So that's all there in this form. We have a feedback letter to prescribers where you can give them information on how they've been doing in the last month. The poster, the flyer is based on the poster. We have the letter to families about asymptomatic bacteriuria, what it is, when and when not to treat it. We have the basic cover your cough poster for your flu season. We have more education for patients and families about UTI, leadership support statement. This is to come from leaders to prescribers, from your administrator to a prescribers, the cards that have the minimum criteria, and then let's see, I think that's a repeat, the quarterly or monthly prescribing profile for clinicians. And then we have the data collection tools. So these are some of the Excel spreadsheets: the antibiotic use tracking spreadsheet, the Foley catheter observation tool, the hand hygiene tool, the point prevalence survey with instructions in detail how to do it, and then a radar plot, which is a way to display your data about how you're doing with a bundle, such as multiple requirements for what you need to do when you prescribe. How are we doing with, is everybody getting duration, or are we only 80% on duration, for instance? Then a sample monthly summary report. Then we have all the gap analyses. I created these basically so that you can get on 1 or 2 pages all the elements that you should be doing. I think that's it. But let me go back to the slides and see if we have anything. We're almost done. Yeah. I think that's it.
I just wanted to make sure this was sent out to administrators and directors of nursing and as many of your infection prevention folks as I had contact information for. But this CDC and CMS have worked together to create a free online training course for infection preventionists. And so I just wanted to make sure that folks had that link. It was sent out recently, like toward the end of last week. Andy, I don't know if you have an opportunity to pull up some of the screen shots of the modules, but it's a 15 module training, some with parts A, B, C, et cetera, to them, that covers everything from, basically the role of the infection preventionist, water management, linen management, antibiotic stewardship, catheter care, et cetera, respiratory hygiene. So very comprehensive, and we wanted to make you aware of that. Yes, I just pulled up so you could see what some of the modules entail. And what was sent to everybody was an email from me with this little description of the infection prevention and control training. So you have to set up an account, and we're offering assistance for folks to do that because there's some different steps that you need to take to enroll. So if you didn't receive this, if this looks completely foreign or you looked and deleted, just shoot me an email and I'd be more than happy to resend it to you or to other folks on your team that need this information.
Okay.
Okay. Well, thank you everybody for participating. And I hope to hear more about your accomplishments in the future.